I'd like to introduce Claire MacLaine, our speaker. Claire is a speech and language therapist working in brain injury. She's a rehabilitation case manager for HCML, based in Edinburgh and working across the north of England and Scotland. So today, Claire is going to be talking to us about communication challenges. And we'd really like you to use the chat function and the Q&A. And at the end of the webinar, Claire will come to your questions. So we hope it'll be a really interactive session. And thank you again, Claire. I'm going to hand it over to you.
Past, the future and the present walked into a bar. It was tense. Comic Sans, Time New Roman and Gothic, Century Gothic walked into a bar. The barman said, "Hey, get out. We don't serve your type in here." A Scotsman, an Englishman and an Irishman walked into a bar. The barman said, "What's that, some kind of joke?" So, you had a cognitive communication impairment. None of those would have made any sense to you. We use language all the time to explain our inner world, but we use our cognition as well. Now, we can't differentiate between the two. The two are compatible, they go together. So cognitive communication disorders is basically how we process the world, with everything that's going on around it. And when I've worked with clients who've had a brain injury and have cognitive communication impairment, the way that they present in the world is very, very difficult. How I imagine they perceive the world is like being a chameleon on a piece of tartan. So as we know, chameleons change their colour to blend into the environment. But if you were a chameleon on a piece of tartan, you're going to have to be a lot of colours, and that's very, very confusing. When people have got a cognitive communication impairment, there is a lot of information they need to process, and it's very, very difficult. And I often call it a covert disorder. It's covert because we don't see the impairment they've got, and they don't know they've got the impairment either. If somebody has a language problem, such as dysphasia, it's very, very easy to pick that up. If somebody doesn't know that this is a glass and they can't tell you it's a glass, you know they've got a language impairment. But the problem with cognitive communication impairment is that it stunts people in every area of their life. And I would say that as clinicians in the UK, we're not the best at picking that up, mainly because we don't have robust enough tools, and also we don't have the time to sit down and process what somebody is not processing. So, very brief tour of the brain areas. So I will do that. And we know there's different sides of the brain that have different functions. I've got a cupboard full of speech and language therapy tests. Some are for the left-hand side of the brain and some are for the right-hand side of the brain. And where somebody has a damage in the brain affects the outcome that they have. Now, I would say for the longest time in Western medicine, we've been very reductionist in our approach to managing people with injuries. We tend to look at the part and not the whole. So I've got a lot of tests that look at parts of the brain, but what you need to look at, how does somebody function out in the real world, IRL, in real life? You need to look at the whole. And we're not always got the time or the test to pick that up. So we've got the tests that look at the left and the right. We've got the tests that look at top, middle and bottom. So we've got the cognitive functioning, the emotional functioning, and then the sort of reptilian or the survival brain. So if somebody's got damage to the left or the right, or the top, middle or bottom, they're going to have a completely different type of presentation. Now, as time's gone on, we've been able to devise much more complicated assessment tools like functional MRI, like SPECT machines. And then what we could do is we can look at all the fibre connections that go across the brain. So when I was at university, which was in the early 90s, we're very much taught just to look at the part. We didn't look at the whole. We didn't have the technology back then. And now, if we look at somebody's brain, we're still assessing them just that part, but we don't look at the knock-on effect for the whole. So when we communicate, we're using all of this. So we might just have one part of the brain damaged, but as you can see from this scan, there's all of these white matter axonal connections that if that's disrupted, then the person's got a problem with their communication, with their cognitive communication. And that's really how they function in the world. So if you've got, I'm going to look here, I looked up, what does a speech and language therapist look for in communication when they're doing an assessment? And this was a picture that I found. I think that's pretty good in terms of what would we consider. Most people think speech and language therapists look at speech, which is just how our muscles move. They look at language, which is obviously the words we use. But in reality, if you've got a speech and language therapist that works in brain injury, what they would look at are all of these things. But what I would say is missing in this is vision and hearing. That is very, very important, and it's missed a lot in a lot of assessments. As a speech and language therapist, when I've worked clinically, or as a case manager working for HCML, I find that a lot of clients who've had brain injury have never had their vision and hearing tested. And that is absolutely integral into being able to function with your cognition and your communication. Now, I don't just mean the function of the eyes and the ears, can you see and you hear? I'm really meaning the neuronal aspect of how the brain processes what we see and we hear. And very, very few clients I've ever had as an SLT or as a case manager have actually had that tested. And that's the very first thing that I would do. I would say to somebody, you need to go at least to Specsavers or Vision Express, get your vision and your hearing tested. And very often I write in my reports, we need to get that tested, because that is all part of our cognition. Being able to process information, sensory information processing is key to how we actually process everything that's going on out there. So as an SLT, if I'm going along to assess somebody, this is all the kind of things that I'm looking at. And I'll come on to later for why things like stress and anxiety are important. And that's when it's important for us, not just as a case manager at HCML, looking at all the different therapist reports, not just as an expert witness for NRC, I need to read all the other reports, but as a speech therapist, I'm wanting to see how is the patient functioning with occupational therapy, how are they functioning with neuropsychology, how are they functioning with physiotherapy, and then that gives me a greater idea of how their cognition is processing to then take it into the world and then live their life again, which is what they're wanting to do after they've had their therapy. So this is something that I came up with in my master's degree when I was doing that at Strathclyde University. I was looking at what is the subtext issues people are having in language. So I don't just mean subtext in terms of facial expressions, gesture, tone of voice, but a lot of people with brain injury can't pick up on the subtext. And that's where they're falling down in everyday life. That's what's stopping them from going back and getting a job. That's what's stopping them from reintegrating with their friends, having a family life again. Because central coherence is when we pull all of this information together to make sense of our world. Now, this isn't information that I found from the speech and language therapy literature or from the neuropsychology literature, which is most of where I would get my theory background from. This actually comes from autism. This comes from the research that's been done by Simon Baron-Cohen, who's the cousin of Sacha Baron-Cohen at the University of Cambridge. And what he's looking at is like, how do people who don't have a particular deficit in their brain, like a brain injury, not make sense of the world around them? He came up with this term, central coherence, and it's pulling in all of this information. So if you go back to what I was saying about this part of the brain's broken, if we work from a reductionist model, which is we treat that, we're missing all the other part of the brain that's stopping the person from making sense of the world, the central coherence that makes sense of it all. So to put this in real world terms, recently there was a signal failure at the train station in Newcastle. So of course, Newcastle is pretty central to the East Coast. The trains couldn't get down from Scotland. The trains couldn't get up from England, and the trains couldn't come across the way from Lancashire and Yorkshire up to Newcastle. So there was this massive bottleneck. So it was only Newcastle that was out of commission, but the impact it had on the wider area of east, north and south, so west even, as me having a central processing problem, was huge. When we're working with our clients, not considering all of this, then we're going to be doing a disservice. If we're working with people and we're doing individual assessments, I would say from a solicitor's point of view, and we're not putting it all together, you're going to be missing out on a whole load of cognitive communication impairments that person might have. That's going to affect how they rehabilitate into everyday life. It could also affect what their claim is worth. So this is the most famous guy in brain injury. I'm sure he's absolutely thrilled that this is what he's famous for. Phineas Gage, I'm sure a lot of you have heard about him. So this was the first person that doctors thought, there's obviously a map in the brain. There's a map that processes very particular information. So Phineas Gage was a railroad worker, and a steel bar went up and went through his frontal lobe. Now, he initially was apparently a super nice chap. And then after this accident, apparently he was a gambler, a womanizer, and a drinker. So, you know, could have been just been from Glasgow. But there's nobody Glaswegian on the call. So there was this profound personality change. Now, here's a scan that they did that recreated what it would have been like to have Phineas Gage's injury. Now, if you see, very particular frontal lobe impairment, but if we're putting modern imaging on top of that, see all the neuronal connections that would be all across the brain. It affects so many places. It's going back to the Newcastle train station analogy. That one bit is out, but all around here is unconnected. He's not going to be able to pass the information between left and right, between this level, and this level, and then all of the emotions that come with that, all the sensory processing. We don't just function from our brain, we function from our body. It's all connected. And the more research that's coming out, it's looking at how does somebody process their interoception, what's going on with their sensory information inside that makes them process things in the brain that makes them act appropriately. Now, a lot of people with frontal lobe impairment, as we know, could have behavioural problems or personality changes. But also, if they're not getting the sensory feedback from their body, or they're getting it, but they don't know how to process it, that's all part of our cognition. Now, this is another problem with language. Language, especially the English language, is ambiguous. I don't speak any other languages, so I don't know what other languages are like, but the ambiguity in the English language, I'd say, really is a barrier for us being able to properly rehabilitate our clients, because again, we use this very separatist language. So, coming on to language. When we're talking to our clients, I'd say there's an assumption that they understand what we're saying, unless, of course, they've got a very overt dysphasia. So it's not what you say to them, it's what they hear. That's what we need to be working on. But unless you've had a very thorough assessment from a speech and language therapist that works in brain injury and knows what they're looking for, I don't talk about the hospital assessors. They assess things very differently and they don't assess it in depth. So an assessment from an acute speech and language therapist, to me, wouldn't be a viable assessment to use in a medical legal case. You need somebody that's worked with the person in rehabilitation or in the community. So here's the joke about the guy that phones into work and says, I can't come into work today because I've got a week off. And his work colleague says, I'll see you in 7 days. So one time I was working in neurosurgery and one of the nurses said, I hadn't seen you for a while. And I said, oh, I've had a week off. And she said, oh, you feeling better now? I said, well, I was never sick. She said, you had a week off. I said, yeah, I had a week off. So just even that is enough to throw somebody completely off. Now, for you and I, who've got normal hearing and normal cognition, there can be a misunderstanding. It happens all the time in human communication, misunderstanding. With our clients, it's more so, and they don't know that they don't know that they've got this issue. So we've always got a different perception. And the problem with a lot of our clients is they're acquiescent, and I'll use this word a lot. A lot of brain injured clients, especially with a cognitive communication impairment, are acquiescent. They passively agree, but they don't know what they're agreeing to. So they see something from one perspective, you see it from another. Now, I frequently have clients say to me, I spoke to the doctor and I don't know what he said. Can you tell me? And I said, well, did you tell him that you didn't understand? And they said, well, no. I said, why not? Well, I didn't want to seem like I didn't understand, but you didn't understand. I've had clients say the same thing. Their lawyers have told me something, but they don't understand what's been said. So in medicine, in law, there's legalese all the time. Now, the language becomes quite implicit. There's things that I know, but I've known for so long, it's implicit information in my head. I sometimes forget that I have to make it explicit. If we're using the language all the time, our clients won't know. So there's that status thing as well. If you're a lawyer, I would say that you're you know, in the social context, got a higher status than your client. They're going to sit there and passively agree. They'll just nod and say yes, and they don't have a clue what you're saying, and then they come and ask me afterwards. Sometimes I'll read the emails that a lawyer has sent to me and I don't understand it either. So here's the process. Is it a 6 or a 9? Is it, what's your perception of something creates your reality. If you've got impaired cognition, you might only see the 6, but not have the cognitive flexibility to see the 9. And they're not going to tell you that. And this is where they fail. Now, I have read lots and lots of reports from other speech and language therapists, from OTs, from neuropsychologists, within speech and language therapy, within Medico-Legal, within HCML. And I see, no offence to my colleagues, but how much has been missed because we do these tabletop assessments. And the tabletop assessments only give us a snippet of that person's function or a snippet of that person's dysfunction. And we're missing this sort of 6-9 scenario. We're assessing them one way, but they're seeing it a different way. Now, this slide isn't incorrect. And when we use the language of somebody with a brain injury with cognitive communication impairment, we quite often say they're concrete. Their ability to be cognitively flexible has been impaired by the accident. So I would assume that if any of us said to our brother, you can eat half my grapes, and there's 12 grapes, we'd assume that they would have ate 6 of them. But again, going back to English language, it's very ambiguous, it's very intangible, and it can be interpreted lots of ways. And a lot of people with brain injury are very concrete. So if you say you can eat half my grapes, then that's completely accurate. That's eating half the grapes. What I've found with clients who've gone back to work, who, if this has not been properly assessed, they fail. And a lot of the clients themselves don't know that they don't know. I've had multiple clients, and I'm sure lots of you on this call, the therapists, the case managers, the lawyers, you have clients that think they're going to be able to go back and do their everyday job, but they can't. I've got a couple of clients just now, both of whom are in the north of England, both of whom had very complicated jobs that required a high level of cognition, a high level of language, and a lot of diverted attention. Both of them think that they could go back to work, but I can tell just within conversation that that's not going to be possible for them. Now, I'm not going to tell them that yet. They're still at the beginning of the recovery. I don't think they would want to hear it anyway. But the way that they're able to process quantity of information, their ability to divert attention, their concreteness in conversation, I can see that's going to cause them problems when they go back. Now, I don't have as much experience reading medical legal reports as the lawyers on this call do, but from my limited experience, I would say the depth of the assessment misses all of this out. And obviously, I am an exponent for my own profession, but I think if you've got more speech and language therapists involved in an assessment for cognitive communication, you're going to pick up a lot more deficit. If you're a defendant solicitor listening to this, I don't think you'd want to hear that. If you're a claimant solicitor listening to this, I think you would actually find there is a lot more problems going underneath that those tabletop assessments that you would get just can't pick up. Because this is what stops people in their relationships. This is what stops people going back to work. And I've seen lots and lots of people over the years go back to work and then they fail. And they actually don't even know why they fail. So what I'm going to do is just give you an example of language and how it can be misinterpreted by everybody. So we were asked for a piece of paper. I hope we've all got one. It doesn't have to be A4, but it would be better if it was A4 because then we're all on literally the same page. What I want you to do is, I want you to fold this piece of paper and I want you to follow my instructions. If you're in a room with somebody, I don't want you to confer. I don't want you to look at theirs. I just want you to do it by yourself. So I'm going to do it as well. Normally I would do this in a room and we'd all hold up our paper and we'd see. But what I'm going to do is I'm just going to show you my paper at the end. So I'm going to give you a couple of minutes. So I'm just going to give you some instructions, right? I would like some background music as well. While I do this, but I can't do both at the same time. So fold your paper in half. Fold it in half again. In the left-hand corner, tear a square about an inch. I know some people are going, which left-hand corner? This is the point. Language is not specific. And we, when we talk to people, are not specific. Because we think, well, I'm thinking 9, they're thinking 6. Okay, fold it again and tear a semicircle about an inch deep in the middle. You've done that, open it up. On the bottom side, tear some strips. About, let's see, 1.5 inches. Then in the bottom corner, cut out, try to make it like a triangle shape in the corner. Right. On the left-hand side, cut out another square. Now on the top, probably about 2 inches away from the middle on the right-hand side. 2 inches away from the middle on the right-hand side. Did she say that? I just did. Do another tear. Then tear that tear at the bottom to the right. Oh. Now, what we need to do is open up that bit of paper and have a look. Right, so that's my instruction. So obviously what I said was right because it came from my head. And that's what it looks like. So in the chat, if you wouldn't mind, could you put a yes if it looks exactly the same as mine? Because I mean, we all had the same instructions. So I'm assuming everybody's bit of A4 is exactly the same. So in the chat, can you put a yes if it was right? Anybody's chatting to me? Anybody chatting? No. Only one person. Only one person with a bit of paper, maybe. Right. So you know what the point is? Point is we all hear the same instructions, but we get a different result. And that's every conversation. We do this all the time. We do this in our everyday life, don't we? So if you've got somebody who's got all the background noise that goes on in life, and I mean background noise isn't literally noise or the noise that's going through our head, they're going to have a difficulty processing. So this is how I imagine life with a cognitive communication impairment or the brain injury. So some of you will recognise this. This is the traffic light tree at Canary Wharf in London. Somebody who's got a brain injury, they're processing all this stuff. So, and I'll say this over and over again, vision and hearing is not checked very often after the brain injury. That is massively important to be able to process information. So if you've got visual and hearing impairment, you've got the background noise, you've got people walking past the window, you've got that internal chatter, that little voice that always goes on inside our head that sometimes can be chaotic. You've got patients who are in pain, you've got people who are sleep deprived, they've got medication side effects. There's all of these things that are going on. They might have some other medical conditions as well. That's going to affect their ability to stay focused. And one of the things that we got taught at the very beginning in speech therapy at university was attention. You need attention. If you don't have attention, you're not going to be able to do very much. A lot of our clients with brain injuries, you know, have got very distracted attention. Now, sometimes that distraction is overtly external, like, you know, they see something moving past, but it could also be internal. What we find is that if we're doing an assessment, and I've found this a lot with myself and with my colleagues, we're doing an assessment in a very controlled environment. We're in the patient's house or we're in our clinic room, and we've got this controlled environment that's nice and quiet and clean and tidy, and we get rid of all the mess, we get rid of all the noise, and we do a very focused assessment. I would say to those solicitors out there, that is giving you false positives because you're filtering out all the information that distracts that person from their cognition. Then we want to do that. We want to get the best results for the clients, but sometimes that could be false results. When I used to do tests with people, I used to do it in different ways. I would do it in the morning, I would do it in the afternoon, I'd do it before lunch, after lunch. We're all like that. You don't want to, if I was to do a test at 9 o'clock in the morning, I would get an extremely low score because I'm not a morning person. If you've got about 4 o'clock in the afternoon, then I'm better. Pre-lunch, post-lunch, all of those things. When somebody's had their medication, are they due their medication so they can't focus? Have they just had their medication? So now they've got side effects. All these things affect somebody. So I'm just trying. So this is just a snippet of what goes on with cognition. So that's just a little example of how we process cognition. Cognition is a massive topic in itself. Now, a couple of things that I've come across over the years that really isn't addressed at all, not from my experience, it might be someplace, but is time and space. Now, I don't mean in the Stephen Hawkins or Professor Brian Cox version of time and space, I mean the here and now. When I was at university, we were told they couldn't find where in the brain time was processed. And now they do. It's called the entorhinal cortex. But, like anything, you can't just say that that entorhinal cortex there, if that's damaged, is going to impact on somebody's ability to process time. All the structures around it, if they're damaged, it affects somebody's ability to process time. And what's very important is that I bring your attention to the hippocampus. So the entorhinal cortex is at the end of the hippocampus. And as we know, the hippocampus is basically like a triage nurse for memories. So hippocampus gets a new bit of information and says, here's somebody at a party that I've never met before, I'll never meet again. His name's Tony. I don't need to know that. Well, it's out. Here's my friend's new boyfriend. He's called Tony. I need to log that information because I'll be talking about him again. Right, I'll put that there in my left temporal lobe. Right, I'm going to a dance class, so I need to learn to move those moves. Right, I'll log that in the right parietal lobe and the cerebellum. Right, so the hippocampus is the gatekeeper of all memories. It's the triage nurse which knows where to store something, bin it, and where to put it. The entorhinal cortex, if that's impacted, our ability to process time is skewed. Now you think, what the hell's time got to do with cognitive communication? Well, I'll tell you, it's got a lot. So for those of you that are young, you've probably missed out on the joy that is Father Ted. So Father Ted was a comedy set in Ireland in the 90s, and there was a character called Father Dougal. I could explain all aspects of cognitive communication disorder just with Father Dougal. If you're not used to Father Ted, this might be a little bit out of context for you. But I recommend if you're looking for something to do this weekend, go and binge it on YouTube. So if we lack time, language, our ability to process our life is really impaired. Now, I've never come across a test that processes time. I've never come across, I mean, the occupational therapists on the call or the neuropsychologists might have something. I've never seen it, not in the UK or when I worked abroad. But time, the language around time and space is hugely important to someone's cognitive abilities. There's also research that says if we cannot move, physically move, our ability to process time is also skewed. Now, I don't just mean the proprioception. The physio is better to explain proprioception than I would be. You know, proprioception lets us know where we are in space. But in terms of time, if we're stuck, if people are spinal cord injured or in a wheelchair, their spatial language and time language is skewed. This is important because the patients that I've had who've got problems with time and space language really, really struggle when they try to go back to work. So from a medical legal point of view for the solicitors, this is hugely important that this is picked up because in your standard tests it won't be. How do you pick it up? Well, I would say the test should be done out in the community. Tabletop tests don't pick this up. What I want to do is go out and see what somebody's like out and about in the world and how they process it. That's going to take time, which is something that a lot of us don't have. And time, of course, costs money. But if we're missing somebody's inability to process, I don't mean time as in telling you it's 4:30, but like time as in the language of time, which I'll come on to, it makes it very difficult. So this is just a little example of the kind of patients that I used to work with. So if somebody's got difficulty with processing time, not just that internal awareness down in the entorhinal cortex, but their language ability, they actually miss out on a lot. And this is I think it's very serious. As you can tell, I'm very passionate about it. You know, there are books on the use of language in space and time. And I don't mean space and time away out there in a galaxy far, far away. I mean the here and now. So there is this look at how we process this cognitively and it affects our life. So there's all of these words in the English language, they're very intangible. the English language is not monosemous. Now, monosemous is the opposite of ambiguous. There's not one definition for very many words, apart from triangle. Triangle is very monosemous. But most of the language that we use are just throwaway words. We're not going to be aware of this. Could you imagine the amount of effort it would take from us to be able to explain to somebody not using intangible and not using ambiguous language? We wouldn't get very far. It's everywhere. So, for example, soon. What is soon? You know, I would say to patients, I'll see you soon. And those with a brain injury would say, well, when? And I'd say soon. It's a very intangible language. We use it all the time. So, for example, or use the word soon. Okay, I'm Claire, but I'm not voyant. But I think I've got a message coming through. I've got a premonition. I think that very soon Australia is going to beat Scotland at the rugby at Murrayfield. I think that's going to happen on Sunday. So there, it's going to happen soon. That's Sunday. But then I might be able to say, well, I think very soon, it's going to be pretty soon, I think Scotland's going to get their, what, 5th Calcutta Cup win, I think at Twickenham in February. Do you know what I mean? So soon is flexible. Is soon 2 hours? Is it 2 weeks? Is it 2 months? You know, it's so intense. These people can't handle it. So we need to be responsible for our language. How are you going to know that a client's going to have difficulty with this? Well, that's where you need a robust assessment from speech and language therapy. So another thing is perspective. This is the Camera Obscura in Edinburgh, which is great fun if you're ever up here. Spend a couple hours. This is a room that is the same size, but where you stand in the corner of the room makes you seem taller or smaller. So perspective, it goes back to that 6 or 9. It goes back to the eat half my grapes. So we've got the language perspective, but you might have a visual impairment that the person's got on top. How they process this in their brain and their body affects their communication. I would say I have tried many years to teach people spatial language and time language, and I've not been successful. So what do you do from a speech and language therapy point of view? You have to modify the environment for that person so they're not overwhelmed by the language. That's all well and good in a therapy situation, but not out there. So there may be a speech and language therapist, a neuro-OT or a neuropsychologist that has some skills in teaching this. I don't know any, but they might be there. But the real world doesn't allow folk those compensations to change the environment for them to make sense. So again, going back to the 90s, those of you that are probably the age of 45 and older may be familiar with the magic eyes. Now, I could never ever do a magic eye in the 90s and the noughties, but I can now. Don't know what's happened in my brain to make it happen now. But some people just see a whole load of coloured shapes, but there is an image in there. I don't know if anybody can see the image. And if anyone can see the image and put it in the chat. Well done, Leanne Day. Yeah. Can't see it. Oh, the brain damage. Yeah, Camel. Good. I spent nothing. Hilary. Right, I'm going to have to do an assessment with you, Hilary Dennis. So I guess for about 15 years I tried this, and now I can see it. So this is all about perspective. I have argued with people in my youth, Camel, good, Ali Motti, and they can't see it from their point of view. So Amy O'Connor, just colours, a giraffe close, Timothy Wilson, a human face. That is a well-deformed human face, Sammy Silvana. Nothing. Can you see where the head is? Let me just. Beth Bartlett, come on, expected more from you. Use your magic skills. So you see what I mean? Everybody's seeing different things. Some people saying a giraffe, some a camel, which it is, but a camel with stuff on its back. Some people say nothing. If you've got a cognitive communication impairment, you're solid. You're solid. Solid. I'll give an example of what solid is in case you didn't know what solid was. Their ability to flex is difficult. We're sitting with these tabletop assessments. It's very difficult to get this deep understanding. I remember one time I was working in a brain injury unit, and oh, Nicola Cockett, don't blame your menopause on that. There was a client and he did really well in the speech and language therapy tests, the right hemisphere cognitive stuff. And he did really well in the neuro-OT test. He did really well in the neuropsychology test. And I was speaking to the therapist and I was like, he's just not functioning. What is it? And one of us said, on paper, he does really well. But in the unit, he did not function at all. He was so dysfunctional, but we couldn't pick it up. And this is what led me to go back to uni to do the masters and looking at what are we missing in the subtext. And what came back to it was that central coherence, that ability to pull it all in and make sense of the world out there and in here. Now, I've taken loads of clients out on visits when you think they're ready for it, because when they come into the therapy unit, obviously they're doing therapy with me, the neuro-OT, the psychologist, the physio, they're getting better. And then they go into the real world and it doesn't function. So this to me, when I saw this, I thought this explains brain injury perfectly. This is like me trying to explain this to my patients in a clinic room. So you can imagine trying to figure that out in conversation. That, like, our whole conversation is littered with, and I've just used an example of it, littered with examples. We use figures of speech in every language. So every language in the world has figures of speech. So trying to explain abstract concepts like these are, I mean, space and time and language, it's all interwoven. We can't separate it. And that's where the cognitive communication comes in. So they're everywhere. So we use it all the time. We're not even aware of it. So a hyperbola, I'll give an example of a hyperbola and litotes. So litotes would be, I've got nothing to wear to the HCML Christmas party. Well, I do. I just don't want to wear what I wore last year. I've been to the shops and everything in the shops is just all glitter. I don't do glitter. You know, so litotes is an understatement. Hyperbola is an overstatement. But in everyday life, we use it. And if somebody's got a cognitive communication impairment, they can be very concrete in that. And coming back to, I've seen people fail so many times at work because of that, and relationships. Now, we all know this, people with a brain injury, especially if they've got any sort of personality changes, their relationships quite often falter. Now, what makes our personality? It's our whole life experience. It's our family background, it's our society, it's our community, it's our life experience. That all comes out in our language. How we express ourselves, everything, how we dress, that's all an expression of our inner cognition. When people don't understand this, it's huge. So I want you to tell me in the chat, what is the British version of this? So in Spain, when frogs grow hair, is the same as in France when chickens have teeth. It's the same in Russia when lobsters whistle on top of the mountain. What's the British equivalent of that? Yep, Timothy. Yeah, yeah. Okay, when pigs will fly. So that's right. It's a shorthand. We all use this shorthand. There's a test that we use in speech and language therapy called the Mount Wilga high-level assessment from just north of Sydney, Australia. And we use this analogy. And we've got a whole load of expressions like they'll fly off the handle. And I've had patients get up and walk to the door and look for the fly and couldn't find it. We take this for granted. It's so embedded in our language that we're oblivious to the fact that it's there. So the problem we're having, so coming back to this, is supposed to be from the medical legal point of view. If we're testing just in the testing room and we're not seeing what they're like out in everyday life, we're missing an awful lot. And that's got impact on the claim. Now, defendant solicitors, you don't want this knowledge. It's not in your interest. Claimant solicitors, it very definitely is. Therapists on the call, it very definitely is. I have had so many clients that have not been referred to speech and language therapy because they can speak fluently, but cognitively, I'm just there as a case manager from HCML. I'm there picking this up, going, hold on a minute, what's going on with this? But then again, I've been taught how to do it. I had a patient called Leighton. Now, Leighton had his brain injury at 14, and he was now 24, and he wanted to meet girls. Leighton had been in brain injury units or been at home with his parents for the past 10 years. Now, where do we learn how to socially integrate. We learn it from school. We learn it from jobs. I mean, when I was 19, I got a job in a restaurant, and I feel that that improved my sort of social cognition, I would say, because I was with older people. You know, we get jobs, we go on holiday, we travel ourselves by train to other places. All of these things just slowly embed into our brain and improve our communication and improve our social skills. Leighton had missed out on that. From 14, when he should have been doing all that. Now, Leighton didn't know how to flirt. So what we did in the clinic room was that we prepped, we planned, we discussed, we role played how to chat up girls. Now, I don't know if there's any other speech and language therapists on the call, but in my university, we didn't get lectures on teaching people how to flirt, right? So you learnt to flirt in the old days by going to the pub and trying and failing and being drunk, if you were Scottish. So Leighton had missed out on all of that. But when we went out into the community, what we practiced in the room that was very much led by me, and then, you know, he's trying to flirt with me in a really terrible way, just didn't translate out there. So Leighton would go out and he'd go right up to a girl. He was a really big guy. He'd go out to girls and he'd go, "Will you go out with me?" So I'm going back. I'd say, no, Leighton, you can't do that. You can't do that. You can't do that. He said, "Why not?" I said, "You just don't go out to a girl in a supermarket and say, 'Will you go out with me?'" He said, "All right, okay." So we come back, we do a bit more prepping. Next time he goes out to a girl, we're in the library. Not that the library is a place to chat up people, but we're looking for books. He sees a girl he likes. He goes right up to him and goes, "Will you go out with me?" I said, "Oh." He said, "Leighton, you don't go up to a girl in a library and do that." So we come back, we do some more prepping. Next time we're someplace else, he does the same thing. Leighton said, "You never said to me that I can't ask a girl out in a, I don't know, it's like a supermarket." Because I've given them this concrete example, you can't go up to a girl in the street and say, "Will you go out with me?" You can't go out to a girl in the library and say, "Will you go out with me?" You can't go up to a girl in the... So I had to be very specific. He couldn't generalize. So this is the whole point of cognitive communication. We have the flexibility and we generalize that information. He couldn't do that. He couldn't put I taught him within a circle, and then I taught him within a box, and he couldn't think in the circle. If you're assessing somebody in a situation, we tend to just be within that box. And this is when I do my assessments with people, whether it's from HCML or whether it's a speech and language therapist, I deliberately go off what I'm supposed to be doing, and I do lots of, somebody used to call it once, 20 language. I'll deliberately change the conversation. I'll make it go all over the place, and I embed things in. This is if I think they've got, not with everybody, a cognitive communication impairment, to see how they process the information, how they can go off topic, how they can come back onto topic. I ask questions about time, but obviously I know everybody's not able to do that, but that gives me a deeper expectation of how I think they're going to function in the community. So I'm just aware of time. I'm going to go through memory problems a bit, because I can talk about this for days, as you can see, so I'm aware of time and I'm running over. One thing to remember, because we're giving them a lot of information that they probably can't take in, because of all the other issues they've got, memory is hugely important. You need to remember, I would say, 3 things: primacy effect and recency effect. People are more likely to remember what you said at the beginning and the end, and that's been tested over lots of things. Emotional memory impacts on recall more. So if we're saying something that's more emotive, somebody's more likely to remember it. Makes sense. If we say something at the beginning, at the end, reinforce that. If you're a lawyer and you're wanting your client to remember something, they probably won't remember a middle. Remember the beginning, the end, and emotional. I was remember about this, the blue jumper. What's salient information to us might not be salient information to them. So if you're wanting somebody to remember something, say less and say it more often. Because our clients have got an extra cognitive load. They've got a cognitive load that we don't have. So the reason I put this up, this is a picture of MI6 in London. And the reason I put this up is that I once applied for a job at MI6, and obviously I didn't get it because I'm talking to you just now. And in the testing, they add the cognitive load. So they add more questions that are more complicated, and they give you a time limit, and the time limit gets shorter and shorter. So if you've got clients who have got a whole lot of medical problems, are in pain, got medication side effects, they've not slept, they're worried about a court case, they're worried about liability, that all these things that they've got the legal side to deal with, and they've got the medical side to deal with, and they've got all these therapists coming in, and they're overwhelmed with all their appointments, and then they've got a cognitive communication on top. They're not going to remember an awful lot of what's being said. So we need to try and take off that cognitive load for the person. So I'll miss that one out. So this is a very, very famous study that was done in 1999. It's been replicated multiple times. So I want you to follow the instructions on the screen and then write your answer in the chat box. Okay, how many passes did you count? Every time I do this, I get a different answer from myself. 13, 11, 11, 13, 13. Actually, I went a wee bit slower than normal. 10, 13, 12. Right, so look at all these people. Everybody's got a different answer. 11, 13, 10, 12. And Damien did notice. Well done, Damien. Right, so none of us have got brain injuries and nobody got the number right. Some people didn't see the gorilla. When I first saw that years ago, I said, no way, absolutely no way. There's no way I'd miss a gorilla. I was like very seriously concentrating, pushing out all the sensory information processing, and I missed it. So we've got our clients, they've got all this cognitive communication and they've got all of this on top. We've got all these issues that are going on that we're not even discussing. And we come and they're sitting in front of their lawyer or they're sitting in front of their therapist and they've got to take in all this huge amount of information. I've got a client just now with a brain injury who's having so many appointments, because it's not just a brain injury, she's got a whole lot of other things going on. And her timetable is saturated with NHS, private, work meetings, lawyer meetings. She's exhausted and she's missing all these things. I'm thinking, well, without all the other stuff that's in the background, physiological issues, pain issues, sleep deprivation, worry about money, they've got all these difficulties. Then on top of that, not even discuss these other things, apart from vision and hearing, which we will keep coming back to, which is massively important and very underdiagnosed. What about the other speech and language therapy conditions that we deal with? What about all the other problems that they had before in their life? So a lot of the clients I've worked with in the past, especially in Manchester, I have to say, where maybe they'd had very serious psychiatric problems, which led to the brain injury, or they lived on the wrong side of the law and they got into a lot of trouble, which led them to a brain injury. They've been in and out of jail all their lives. They had substance addictions. All of these things go with it. Then you've got somebody who's maybe got chronic kidney disease, high blood pressure, type 2 diabetes. All of these things that impact your vascular flow also impact on your cognition. So I ask the lawyers that are on the call, is that all considered? When you're doing your schedule of loss, is that all considered? Do you bring all of that in? I don't know if you do, but I think you should. So what we need to do is give a pause for our clients, give them time to think. Unfortunately, I've seen that we don't. We're all time poor. We're on a time budget. Everybody's on a time budget. And I've spoken, this is no criticism of lawyers, I've spoken to lawyers on the phone and I tend to find they speak very fast. And then because they're very, very busy. And I sometimes think, I wonder if they speak to their clients like that, because they would struggle to take it in. I know from a speech and language therapy point of view, if the lawyer's speaking to their clients like that, they will not take in what they've said. They may as well not have had the conversation. So we need to give people small amounts of information over longer periods of time and repeat it. And I don't see that happen very often. So it doesn't take a lot for information not to be got through. Now what you'll find is that I've deliberately put colours on these slides. Now the colours are there for a reason. The colour is to make you scan. If we're jumping around with different stimulus, it actually can focus. Too much stimulus, we can't focus. But if you've got different colours, you're more likely to be like, now I'm not saying that as a lawyer, you sit down and you print out legal information and you get the fonts in different colours. But we're looking at, I'm trained on how to make somebody pay attention. And I know about fonts and colours and spacing. It's all part of our training that helps somebody make sense of information not just the actual semantics and syntactics of it, but cognitively. So look at here, here's my phone number, 07463 494 760. But if you switch the 6 and the 0 around, you won't get hold of me. If you take the 0 off the end, you won't get hold of me. And that's it, the tiniest bit of information, and we lose. So you look at all the wee things that we've done here, we've all got good cognition and hearing and vision, and we still make mistakes. It doesn't take much for our clients, like my phone number here, for just the tiniest bit wrong, and you're not going to get through. So the whole process of how I can help you as a speech and language therapist help your clients, that is a whole completely different session. But basically, really to boil it down would be to, I say, not as much over a longer period of time. Give them some breaks and repeat it. So does the person function better in the morning or the afternoon? That's the time to give them information. It's better face to face because they're picking up on all these other cues than on the phone. Light, heat, noise sensitivity, it affects all of us. It affects you worse if you've got a brain injury. What we call in speech therapy multimodal conversations. If you've got, I'm visualising, I'm very, you've got lots of people there talking to you. Cognitively, they cannot take that in. Linguistically, they can maybe understand it. Cognitively, no. Don't give them too many ideas. And I know that people have appointments and they're trying to cram in as much information as possible. That actually becomes redundant. Actually better giving people less over a longer period of time. Look at how you're giving people information written down. And then remember the primacy and recency. Give the most salient information at the beginning, give it at the end, and repeat it. This is the thing we'll miss out because I'm not going to get time. So another thing, we tend to, in the English language, describe things in the negative rather than the positive. This in itself is a whole other training. This is a massive training that I could do separately. How to give information in a way that's going to activate the brain. So I know the way that linguistically we can get things activated. I know how we can embed things more. We tend to say things in the English language like, don't forget. I never say don't forget. I always say remember this. You say what you do want, not what you don't want. So I've said it when we've had patients and they've said don't talk. So the person goes, we stop whistling. So they start doing, you say stop banging on the table. So they go, so they stop banging on the wall. What you want them to do is stay quiet. But we don't tend to give that instruction. This is just very, very, very typical of how we communicate in English. And then a lot of our clients focus on the negative. When we focus on how can you get out of that negative, what we should be focusing on is like, how do we get the opposite of that negative? But this is how I would communicate with a patient, but it's not, you know, it kind of takes training. So come back to the same thing. Say less, say it more often, and give people more time to process it. Try to cut out all the distractions. If you're a lawyer, all the distractions. I was with a client in a lawyer's office in Glasgow, and to the side, the big long table, to the side there was the window, and you could see outside and you could see the offices over there. And then there was the big glass window looking into the office. Now the patient came and sat next to me because I was looking out there, and I got her to switch seats because she doesn't need all that distraction of people walking past. It's something as simple as that. Don't have the client focus in an environment where there's lots of noise if you're trying to give some information. I would say though, from a therapist point of view, if you are a speech and language therapist, neuro-OT, neuropsychologist on this, you want to be taking people out there to get the reality of the depth of their cognitive communication impairment, seeing what throws them off when a car goes past, when 6 people talk to them, when there's a noise in the street, when they see a dog, when they've had a bad day, when they've not slept. How do they function then? Again, I would say this would be something that would takes a while to learn. We need to change our communication to suit the person because they've got cognitive communication impairment, because they're cognitively concrete, because they don't have cognitive flexibility. They don't have the ability to work around it. We need to do it. This takes training. And the problem with this is it doesn't happen out there. IRL, I'm down with the kids on the lingo. IRL, in real life, nobody really talks like this. I can talk like this in therapy to guide the person. I could also do this with an assessment, but I would say it probably gives me a false positive as well. I want to see how they're out there with all the distractions with people who don't communicate like this. Again, if you've got somebody who's a high-level functioning client, who the test results, the tabletop test results from neuropsychology, and their wee graphs, that's the only percentiles up there, doesn't really translate if that person's gone back into a busy work environment where there's noisy machinery and lots of people walking about. So, simple, slow, specific show. That's what you want to do with people, to try to get them focused on your topic. If you are a lawyer listening to this, make it as simple as possible, which I know with legalese isn't always easy. Slow down what you're saying. A lot of people talk fast. Be very specific. So cut away all the stuff they don't need to know, and if possible, show. It's difficult if you're just shoving text. What are you going to show? But give them text that's not too cluttered on a page. This is what I might do in therapy. It's what I would do in therapy. But again, it's not what translates out there. So I would say from a lawyer's point of view, I would, if you were a claimant solicitor, it would go in your best interest for you to get, what if you hiring a medical expert from NRC to actually go out into the community and see somebody in action and how they function. Then you're going to get the reality. If you were hiring a rehabilitation case manager from HCML, same thing. Maybe you need to do a little bit more with the assessments. Let the person go out with them. If they can't do that, it's really helpful for us as case managers at HCML to have the reports from the other therapists before we go and see them, not after we've done the INA, and also speak to the relatives. If we can speak, or the care staff, because then we can ask the questions, how actually do they function? That's out with just our test questions. So there's a bit of a misnomer about chameleons. People think chameleons change colour to hide. The primary reason that chameleons change colour is to socially bond. It's to say, I communicate with you, we're the same, let's be pals. If people can't change their colour, and I mean that in terms of the communication, to match somebody else, they are going to fail, they are going to function less in society. So from a medical legal claim, you're maybe not picking up on what they're going to lose. I don't know how you would factor this into a schedule of loss. I mean, you know, they don't really get on very well with folk. Well, you know, that's the quality of life. If you want to make it specific, you look more at the job and their social life. But we bond through communication, but we need to have good communication to be flexible enough to do that. So I will leave it there.